Well, thank you very much. First of all, thank you very much for such an excellent introduction, very elegant, very discreet, and said everything. Thank you very much. From now on, whenever I go in the world, I'll take you with me, if you permit. Then again, thank you for coming, for devoting your valuable time, for sacrificing to come in the morning. Many, many thanks to the organizers, to Professor Mohammed Ahmad, first of all, who discreetly came to listen to my lecture in Milan during the EADV, and he was such a remarkable person. I said, oh my God, who is that gentleman? Now I realize. To Professor Nisha Pramar for having reborn the STIs issue in the term of dermatovenerological conferences. Then to everybody in the organization, I know very well how difficult it is to organize, to the whole team, but she's hiding there, to Miss Georgia Haber in particular. Thanks, Georgia, for all your efforts, because a lot of people I knew from the correspondence, and now I know that they are alive persons with legs and arms and so on. And then again, thank you all, because it is the first conference in Dubai with a complete STI session. And with great happiness, I will tell that to my good friends, to Professors Ibrahim and Hassan Galadari, who have already invited me a couple of times to Dubai Derma. And so it's not the first time in Dubai, but they had my HPV talk, but they didn't have the whole STI session. So with greatest pleasure, I will tell to Hassan and to Ibrahim Kamani, you are excellent, but Mohammed Ahmed had the whole, and Nisha Pramar, they had the whole STI session. So, thank you. Now, I think we should begin. I think you won't die of boredom, because I have 3 lectures, but it's not my fault. I have been asked to do so. And I'll try to be as, short and as interesting as I could have been. Even, which I'm very happy that the organizers have provided the questions after the session, but if you come to any urgent question, you can even interrupt me. You can say, oh my God, what are you talking about? It's not true, or we have different experience. I'll be happy. So they always, I have to say, to write this in the front or at the beginning of every lecture, so I have no competing interest. But I repeat this slide because we have to understand as professionals that STIs are sexually transmitted. Infective diseases are getting by infection. So whatever we may say to patients, these are STDs or STIs. So we have to be aware of that. It's the other thing what we say to patients, because sometimes the patients don't want to reveal this kind of truth. Whenever they ask me in my many decades of experience, they, particularly in Croatia, they adore swimming pools. And it happens that, excuse me, that my Croatian patients spend 24 hours a day, 7 days a week in the swimming pool, because whenever they ask me, oh doc, can it be transmitted to the swimming pool? When I was younger, I used to answer, well, depending on what have you been doing in the swimming pool. But afterwards, now I'm saying, yes, it could be that way too. Because, sometimes we have to accept some kind of lies. This is social lies between the patients and ourselves. They know that they are lying, that I know that they are lying, we are all lying together. But it's just my advice to the younger, and you are also young, at least you look so young, everybody in the audience, is, well, we are not inspectors, we are not policemen, because in that case, you would distance the patient and the truth will be revealed under the carpet. And that's the worst thing that can happen to STIs. So, of course, in the case you might not know where Croatia was, it is the map here. It is the beautiful Middle European countries, Mediterranean, Middle European, and there are some motifs, some greetings. In the middle is from the capital, it's Zagreb. On the upper part is the most famous Dubrovnik, Everybody pronounces it Dubrovnik, which we are very unhappy, but anyway, let it be Dubrovnik, because Englishmen and American like Dubrovnik. And there's the Pearl of Adriatic, and it's Opatija. So I think if you didn't have opportunity, please try to come to Croatia. It is a small but beautiful country. And that's what, I don't want to rise the great debates, but even this dash which happened, I don't like it. Whatever we may think, I know, I realize, in the Commonwealth countries, by the United Kingdom and, all the countries where the late Queen Elizabeth and now the King Charles used to reign, including the United States and so on, they have a little bit separated. They have dermatology, and they have sexual medicine, sexual health, and so on and so on. Well, in the other part of the world is dermatovenerology, and it should be written together. With this dash, it means that it's going to be separated a little bit, and whatever we might think, I think this is not a good idea, because we should be proud of our specialty and not to let them take part by part. Because if infectologists take venerology, then plastic surgeons take facial dermatology, endocrinologists take andrology, and so on. We should be left very, very small. And we have the best and the nicest specialty in the world. So I think we should all be proudly dermatovenerologists. And syphilis is the example why it was like that. Because in Europe, these big clinics, these big Paris, Vienna, Munich, Berlin, Budapest, Zagreb included, were due to syphilis. Because as we all know, syphilis had a lot of skin manifestations. It was progressive disease, no adequate cure, and all the wards were full with patients in different stages of syphilis. So syphilis is just a kind of disease that unites dermatology and venerology. It is a little bit like today. Of course, after penicillin, nothing is to be compared with. But these big dermatological wards and clinics in Europe were mostly due to syphilis. Well, and by the way, we all want to say the STIs are new. No. You are so young here, and every young person thinks that life begins with him or with her. But STIs are as old as humanity is. Having a love affair, secret or public, allowed or not allowed, it is as old as humanity is. Today we think that we have, internet and so on, but, it was always like that. And specifically in the syphilis, it is very important Mediterranean Old World, because as we know, there are two hypotheses of origin of syphilis. One is so-called Old World hypothesis, and another one is that it has been brought by Christopher Columbus sailors after America has been revealed. Well, there are, evidence for the both hypotheses. Personally, I don't think that syphilis didn't exist before it has been brought from America. However, there are evidence in both. This is one of the evidence for the Old World hypothesis, because they say some fetal skeleton from many thousands years ago were from France, so it means before the discovery of Columbus sailors. And it is always like that. Well, fortunately, today we don't see almost this third stage destructive phases of syphilis, this gumma syphiliticum and so on. This is mostly historical pictures, but we never know. Hopefully this will not happen again. So again, nothing without Mediterraneans, because if we follow this hypothesis, this has been done after 1492 in Naples in Mediterranean. But, we have to be careful about that. Well, we have some, as Croatia is a Mediterranean country, we have some historical aspects with this. And there is the last case of endemic syphilis was on the border of Croatia and Slovenia, It was at the end of 19th century. It is very complicated called due to this really Skerlevo disease. And believe me, everybody told me, oh, come on, it is named after you, Skerlev. But it's not. It's the name of the village which is at the border, and there were a lot of historians, Stuli and so on, who have described these diseases. But come on, let's go from history to reality. I know that you know, but just to remind us that this called eroded chancre, or ulcus durum, if we want to be very Latin, are the phases of the syphilis one. But just be aware, please, that we see more rarely and rarely this classical primary manifestation of syphilis. Either it's not registered, not reported by the patient, or something has changed, because this is seen less and less. It can be multiple, not only one, it can be 2 or 3 on the genitalia. It can be anywhere. This one is very discreet, as you could see. So it shouldn't be always with the very margins, It can be, it's usually, classically, it is painless. So this is something that we should be really very careful about. Eroded. And please, we should all be aware that the primary chancre shouldn't necessarily be only localized on the outer genitalia. It can be localized on any site of mucosal or oral involvement during the sexual act. Like this, or very discreetly like this. So it's not always like from the textbook. And this is something that it needs our attention today, I would say. My older teachers, they used to see a lot of condylomata lata. This is the manifestation of the secondary syphilis. Well, today, I think the most of younger doctors would think these are kind of confluent genital warts. And as you could see in my third lecture today, my greatest love are HPV infections. So we have to be very careful to differentiate between condylomata lata and condylomata acuminata, between the manifestation of the secondary syphilis and perianal warts, because the treatment is completely different. And they might look very much alike. I must say, I've seen thousands, almost 10,000s of genital warts in anal region, and just a few condylomata lata, and it is sometimes confusing. I shared with you just it was from about 2 weeks ago. If you see on the left side, the patient has been referred to me as perianal genital warts. And well, it didn't look quite, and I said, come on, let's make the syphilis serology. And syphilis serology was remarkable high. It was treponema pallidum HA hemagglutination test with more than 10,000. And obviously, I said, come on, I'll take the biopsy. And we think it is condylomata lata. Regardless, the patient has been given penicillin, and almost in 2 weeks, the result is on the right-hand part of the slide. So definitely it was the manifestation of the secondary syphilis, because no genital warts would regress after 1 injection of penicillin. So please be very careful, because it could have been even a so-called mixed case. The patient might have had the positive serology of syphilis and genital warts at the same time. So we really have to be very careful, because this is the very recent situation from 2 weeks ago. This is very rarely. This called syphilitic alopecia or alopecia areolaris is really something very rare. These lesions are discrete. I mean, honestly, if the patient would have come only because of that, I don't know if secondary syphilis would have been the first thing I would have thought of. But here, the patient had more lesions, unspecific, And if we see here, that's more clear. So my, well, let's say, tip, I cannot say in the name of all of us, is whenever we have some strange exanthema, some strange rash on the body, please look at the palms and soles very carefully. Because, you know, it can be isolated on palms and soles, okay, it can be anything. It can be drug eruption. But if you have something with on the whole body, with some expressions of the palms and soles, please consider also, it's not said that it is going to be necessarily syphilis, but please consider also at least perform the serology for syphilis, because this is something which was the case in this situation. Well, still, serology is the clue, because honestly, I think very few centers in the world perform the dark field microscopy. We do, but you know, it requires special training. You have to know how to do it, and then again, it's a little bit painful for the patient, because you take this, you scrap, and you have to have dark field microscope. So it's a little bit old-fashioned, but serology is important. Okay, I won't strangulate you with these details, because there is a slight difference between European and American guidelines, but as a matter of fact, the point is the same. We need one, you know, a kind of non-specific, non-treponemal test and one treponemal test. By the way, there have been some changes in United States only. According to their recommendations during the last few years, they have promoted in the United States only one specific test. That is what they've done. But now, there are a lot of articles, you know, indicating that they had a lot of false positive results. So it seems that it is going to be back again to the old European school, that one non-treponemal and one confirmatory test is required. But, you know, at a certain time, it was very so-called progressive and more economically related, that in the United States it was one serological test. They are little and little giving up. So there is, you know, when you say increased incidence, it means increased incidence after a great fall of the epidemiology of syphilis, which happened after the Second World War, because at that time, after penicillin, it has fallen. Now we have a certain increases in all age groups. And now, okay, it is mostly, but not exclusively, in MSM, MSM meaning men having sex with men, but not only, in transgender women, but not only. Please, we should all be very careful. Whenever we say it is you know, in some risk groups, then we forget the other risk groups. Not true. And then again, please be aware, the old dermatologists from France, you know, they said that syphilis is a great imitator, or if we go to say originally la grande simulatrice, it means that any kind of a rash of disease may look like syphilis. Then they said it is for the drug eruption. Then they say for HIV lesions, but anyway, syphilis is a great imitator. And this is a very important part, because we neglected congenital syphilis. Congenital syphilis is in a certain rise, we have neglected it. So please just consider this. And this is something that we need to put into our curricula, not into details, but, you know, because before we used to test mothers for pregnant women for syphilis routinely in Croatia. Now this has been abandoned, and this proved not to be good. But that is the way it is. And these are some of the situations, you know, today the situation has changed. We have especially drug abuse. We have a PrEP and PEP and so on. So some new elements have influenced the change in the clinical features of syphilis. Just as an information, high rise in Catalonia, it is in Barcelona in Spain. And just to the, overall increase, we can see how much is this increase. For each of these diseases, now it's 74% of syphilis. And this is some of the surveys, because I wanted to give you the new data. We always have this uprise, as you can see here. And this is also of a congenital syphilis. These are cumulative data. And now some of the possible reasons for the resurgence of syphilis. First of all, it's oligosymptomatic. It has changed. Don't look today at the classical symptoms, with the primary chancre, with unilateral lymphadenitis, and so on. Then the chancre can be anyway, it can be hidden or not reported. Then we have atypical forms with, oligo or asymptomatic. Then today we have a lot of migration of population. And then again, we have to be aware that professional sex workers, or as we used to call them, prostitutes, they don't work anymore in the fashion that used to be before. It's not always a lady with a finger on the lips standing on the dark corner of the street. Today we have all kind of networking, all kind of, different ways that people get together. So we have to be aware that today's reality is different. And the people dealing with the STIs should always think about the reality. The reality is not always in pink, and this is not always the way we want it to be. And I couldn't resist, this is in honor of Professor Ahmed, because it was the one of, and by this, even from Milan and from Dubai yesterday, I thank you. I think it's 0-0. I'm completely within the frame ranges. It's there, the green numbers. So for the first part, for the syphilis part, I most cordially thank you for your kind attention. Now we go number 2.
For that second.
Okay, I wait for the directors over there to give me number 2. And I hope, I'll do my best. It's very difficult because I have to, even, Seinfeld from United States in the stand-up comedies, and so they cannot entertain the audience for 20 for 1 hour. Oh my God, what Seinfeld would do. I mean, I have to pick up your attention, but I'll do my best anyway. So this is something which actually it's very specific, and I will do my best just to point some things, because if we go in the field of urethritis and in the field of resistance, it is the never-ending story, and it doesn't concern only the STIs. So I just try to pick up some most important items, because otherwise we would all go mad, and I don't want you to give up venerology. You know that? Okay. Now, these are the possible bacterial, well. One of them is intruder. Now I'm asking you, which one is intruder of these 6? Aziz, maybe you can say. I met a fantastic gentleman from Saudi Arabia. One of them is sitting in the first row. Thank you for attending. And I met some lovely people, not only yesterday. One of these 6 is intruder. I mean, it is causing urethritis, but it doesn't belong to the whole group from the microbiological point of view. It's not. All the 5 belong to the same category. One is not. Which one is intruder? Excellent. Thank you very much for that. Thank you. Great compliments to the lady, because Trichomonas vaginalis is a protozoan, is a parasite. All others are bacteria. So all of them are the causative agents. It can be positive. Treponema pallidum not so much, because urethritis, but Treponema pallidum is not so much known. And up to the 90s, we had a lot of antibiotics, a lot of development of the agents against bacteria. But it has been stopped afterwards. And on the other hand, antiviral agents have been now very much increased, but unfortunately, we still have not enough antiviral agents. And we have written several articles about gonorrhea because the important part about gonorrhea is antibacterial resistance. Believe me, you can read that in the literature. When penicillin has been discovered, of course, it has been relief. Oh my God, it was excellent drug for syphilis and excellent drug for gonorrhea too. Whereas it has still remained the treatment of choice for syphilis. Nothing can replace syphilis. Please, maybe I forgot to tell that. Okay, there are some doxycycline options for syphilis, but if the patient is really allergic, my advice is not to go with the comfort of the patient. Oh, doc, I wouldn't like an injection. I would prefer to get doxycycline. Yes, but it's not, efficacy of doxycycline for syphilis is not such as it is of penicillin. On the other hand, it almost doesn't work at all for gonorrhea, and many other antibiotics, meanwhile, they don't work for gonorrhea. So gonorrhea has, Neisseria gonorrhoeae is much more intelligent than Treponema pallidum. Because Treponema pallidum, once been attacked by penicillin, it came like that. On the other hand, Neisseria gonorrhoeae always tries a way to get away from the system of antibiotics that were applied. So it is, the only reason I'm showing this, it is intracellular Diplococcus, because there is a simple test. Well, this is a bit complicated gram, but if we stain with methylene blue, we can do it in our office. It's ready in 15 minutes, and we have, not in all cases, but in the clinically evident cases, we have evidence that this is Neisseria gonorrhoeae. So we have just to stain the discharge with methylene blue. Methylene blue is a very simple method. Of course, it's not like PCR, it's not like Ter-Martin, but it's quite helpful. I showed you that because we have also rise in gonorrhea in the world. And this explains it. Of course, the most common bacterial STI is chlamydial genital infection. So chlamydia is the most common bacterial agent causing urethritis. And by the way, as I'm always for gender equality, whenever we speak about urethritis, it is definitely cervicitis included, because the female pendant, the female situation, it's always cervicitis. There is urethritis in ladies, but urethra is, as we know, very short, and so urethritis is not clinically significant for women. Whenever we say urethritis, we always imply cervicitis in women. So it is important, but chlamydial is the most frequent one. Now we see always we have the rise of Neisseria gonorrhoeae in the whole world. And this was unfortunately interesting, because even from 2008, 2009, the first cases of resistance to cefixime. Cefixime is a very good antibiotic which can be orally applied. At that time, it was the regimen 1 cefixime per 400 milligrams. Today, if we give cefixime, it is 2 per 400 milligrams, but we have had some cases of resistance. And just to, I mean, this schizophrenic photo I'm showing you because up next to me, it is from India. He's actually practicing in Great Britain, Professor Raj Patel, who is the president of International Herpes Management Forum. But next to him is David Lewis, who is being director of UST Africa at the time, and he made the great investigations about antibiotic resistance to gonorrhea. And we were all, 2009, on the UST World Congress in Cape Town in Africa. Well, then again, the treatment of choice, which is still the treatment of choice, we have some resistance, is ceftriaxone. Ceftriaxone giving parenterally is the treatment of choice. But the dosage has been constantly increasing. It has begun with 500 milligrams, then it comes to 1 gram, and today we may give up to 2 grams of ceftriaxone parenterally. Either way, muscularly or venously is the same thing, so it is still, in spite of all the resistance, it is the treatment of choice. They say, especially by British authors, that if nothing works, ertapenem will work. And there are more and more works with ertapenem. But ertapenem, you know, it can be given only venously, and it has some side effects. So far, ertapenem should be left for the really very, resistant cases of gonorrhea. So this is about ertapenem. And please, you are all practicals, you're all practitioners and so on. We should be very careful about resistance. Has the patient really been given the treatment? Has the partner really taken the drug? Was the contact with the real person? You know, they say, okay, the husband and the wife, they have been treated simultaneously. Yes, but the source of infection might have been out of this marriage and so on. So we should all be very careful about that. And we have more and more antibiotic-resistant gonorrhea, more and more articles in the world. So today we can speak about super gonorrhea. It's not banal, you know, gonorrhea, it's not so important, we have drug and so on, much less than chlamydia, okay, but it can be very, very difficult. And of course, today, it is very important, like in chlamydia, the swabs should be taken from different sites. Never forget the throat and the anal region. So it's not enough only the genitalia. It is the rule that applies today for almost all urethritis or cervicitis. Chlamydia, as we know, is... but by the way, it seems very more aristocratic to have chlamydia. It doesn't sound that bad. As you say, you've got a gonorrhea, oh my God, dirty gonorrhea with a, discharge. And if you have chlamydia, oh, I'm aristocratic, I've got chlamydia. But on the other hand, the truth is the other way around. Chlamydia is much more malicious. Chlamydia might lead to pelvic inflammatory disease, ectopic pregnancy, and secondary sterility rather than gonorrhea. Then again, incubation rate is up to 2 weeks. In gonorrhea, incubation rate is up to 3 to 5 days. And the worst problem in chlamydia, that is almost always oligosymptomatic or asymptomatic. Gonorrhea, mostly in urethritis in men, they have such a discharge and such a pain that they go crazy and they would do anything. But in chlamydia, it's like that, it's nothing, it's hush-hush, and everybody is happy. Oh, I have got chlamydia, I'm the part of the high society. But no, believe me, chlamydia is much worse enemy than Neisseria gonorrhea. And we can see we have higher degrees, we have very, very many cases of chlamydia. Well, we thought, especially we were proud in Croatia, because as you know, azithromycin is originally Croatian synthesis. It has been synthesized the first time by Pliva, at the time the factory in Zagreb. But it is still very, very good antibiotic. It can be used, but it is not, as you know, it was concerned the treatment of choice. So there are some comparison, and even in, I don't want to say that the people in Barcelona and Catalonia do sex all the time. No, on the contrary, maybe they have investigated that problem much better than many others. So there's the reason. When we sometimes have, the great outbreak of some infection in some city, It is because it has been investigated there. They had good investigators. Not the people don't like sex more in Catalonia because the people from Madrid, you know, there is always a little bit, you know, antagonism between the Spain and Catalonia. So Madrid and Barcelona. When I was talking about this, oh come on, yes, in Barcelona they only do sex, in Madrid they don't. Oh come on. So I just wanted to say that it also depends on the investigation in that city. So we have this situation, and it is, you know, we have to be very careful about idiopathic urethritis. Okay, sometimes it is idiopathic, but sometimes we haven't revealed, because there are a lot of chronic cases, and in chronic cases it is not so easy to reveal the pathogenic agent. There, of course, today, there is no doubt all the methods for chlamydia detection should be based on molecular methods, either PCR or nuclear test. They are all called in one name, NAATs, nuclear acid amplification tests or assays. There is no doubt about it. I won't go into detail. And as I told you, today the swabs should be taken from different, not only from genitalia. And there were a lot of studies. Well, Schachter and Chernesky are one of the most famous authors, having a lot of experience in the United States, whereas generally on European level, it was, as I have showed you, Angelika study from Vienna, from Austria. And we have the prevalence. And we have, by the way, we have nothing against, it has been very much done in Great Britain. They have the methods for self-testing. You can go to pharmacists in Great Britain and you get the kit for self-testing. So that's okay. Maybe it's sometimes not the same like as if it's been taken by the healthcare provider, but self-testing is much better than no testing. So and a lot of experience has been done in Great Britain. That's your favorite. Thank you very much for reminding us. But the only important thing is not to forget it. Not to forget it, because first of all, there's a great resistance. Why? Because metronidazole has been given in millions of cases, even when it should and even when it shouldn't. Because if you go without any insult, but any lady going to most of the private gynecologists, she would have something. Either fungus or trichomonas. My engineer, she works with me because I also run the mycological lab. She is expert in visualizing. She went to see gynecologist and he told her, you've got candida. And she asked me, can I see it please through the microscope? And she was a little bit amazed. And she said she saw it was artifact. So, you know, whenever, but it's okay. On the other hand, please, whenever gynecologist says to you, to the lady, you have candida and your partner, your male partner should be treated. Principally, if there is no symptoms of balanopostitis or balanitis, no treatment is required. So please be careful about that. So it is, we think that trichomonas doesn't involve men. It does. It would be impossible to have such a large number of cases in women without involving men. But it is neglected. That's one important thing. So we have to really take care about, please, trichomonas. Today, there is PCR. It can be done from urine. Because, you know, honestly, men are not very brave when we have to take the urethral swab. Even when I had, you know, the greatest criminals or mafioso, and I wanted to calm him down, I just went from my office with this for a swab. They were so, you know, so the male gets frightened. Then they get the stories, oh my God, the doctor is going to put it inside, he's going to destroy your penis, and so on and so on. Well, which is, it's not pleasant, but it's not the end of the world. So today you can say to any male patient, PCR can be done from urine. Mycoplasma genitalium is very important. I've shown you on the left, it's Kit Radcliffe from Great Britain. He's a good practitioner. But much more than that, on the right-hand side is Jørg Jensen from Copenhagen. He is the most famous microbiologist who is actually the father of mycoplasma, and all of them member of INT'L Europe, just to remind you how INT'L Europe important is. Well, it is, I don't want to go into detail. We neglect it. Today, we speak about ureaplasma. Mycoplasma genitalium is more pathogenetic or more pathogenic than ureaplasma urealyticum, or especially ureaplasma parvum. Ureaplasma urealyticum is, if it is more than 10 on the third potential, thank you, it's my water coming, oh my God, thank you very much, and thank you. And it is, I don't know if it glance, okay. And ureaplasma parvum in immunocompetent patients have no significance, but mycoplasma genitalium, yes. And that's what I was talking about, idiopathic. What does it mean? We have a lot of, other parts. So there is no definite answer. Doxycycline or azithromycin, in general lines, it can be said that for ureaplasma urealyticum, the first choice should be doxycycline, and for mycoplasma genitalium, the first choice should be azithromycin. But anyway, both drugs can be used in both situations because they've done some experiments, and some doxycycline-resistant cases responded well to azithromycin and vice versa. That's what. It should be really. I put this article, but this should be really taken with care. Mycoplasma, it's really, there are mutations today. Unfortunately, we will face resistance too. But so far, these both drugs might work good. That's what I'm talking about. Because I don't want to get into details. There are really meta-analysis of these studies. And, well, it's maybe another extreme. Today, the English authors said, you don't have to treat ureaplasma urealyticum. Well, in some situations it should be treated. The older system was if the concentration is in quantification is more than 10 on the third potential. Otherwise, don't treat it. That's practical advice. And parvum, no. Parvum is nothing to do with immunocompetent persons. No, not really. This is important. Azithromycin is the treatment of choice for ulcus mola, for Haematophilus ducreyi. It's not a common disease in some parts, but I believe, especially in some tropic parts in India or Indonesia or some part of Africa, this is a little bit more common. In most Europe, no. From all the tropical disease, the only one which has impact in Europe and the United States is lymphogranuloma venereum, but that's completely another story. So these are the drug of choice, because Van der Meyden is one of the leading person who knows about it. And this is the important. We have to combat the drug resistance if we want to make any step forward. And now again, it's again in Dubai. I was happy that once we had been received by His Highness Rashid Maktoum, and he really received us very nicely. And but for me, all of you are Sheikh Rashid Maktoums. So I will have it. Thank you very much. It's my water now. It's come to the third part. If I survive.
I think maybe we can take a few questions for this first two
Okay.
So you can breathe at least.
I agree. Whatever you say, you are my bosses here.
Any question for the two presentations?
Or something you agree with or you disagree with, or something you have your own experience, which I'm sure you do, or something which maybe you have different experience than me. I would be happy to learn too.
Thank you, Professor, for your informative lecture. Just a question about treatment of syphilis with penicillin. You know, there is, we have two options, maybe benzathine penicillin and procaine penicillin. And, you know, they say that it is better to give procaine penicillin as a preventive of the neurosyphilis in future. So what do you think about?
Well, principally, by even not only by my own experience, but also by the guidelines, the treatment of choice is definitely benzathine penicillin. I mean, I would never give procaine penicillin in this indication, but since neurosyphilis, okay, if it is proven and really evidenced neurosyphilis, okay, in that case, procaine penicillin is a better choice. But you have to be sure that this is really neurosyphilis, because only switching from benzathine penicillin to procaine penicillin wouldn't prevent neurosyphilis, because neurosyphilis has a completely different scheme of treatment than a standard syphilis, whichever it is. Today, we don't speak in treatment measures. I didn't want to go into the details. We don't speak so much about, you know, first, second stage, and so on. We speak much more about early and late syphilis. That's what is much more, you know, accepted. In some cases of late syphilis, really, we might miss neurosyphilis. That's true. And today, we also, from that reasons you have mentioned, don't speak so much about neurosyphilis if there is ocular or audio involvement. Especially American authors have introduced ocular syphilis or audio syphilis, not to mix it with the real neurosyphilis, which has complete different manifestations. So I would rather keep to benzathine penicillin, and in some suspected cases get into the evidence of the neurosyphilis rather than give procaine penicillin for this case. But thank you for the question anyway.
Thank you.
So, thank you for your talk. So what about in dealing with seroprevalence in our society? Because I am seeing so many cases of seroprevalence, some positive cases.
From all, I've heard only seroprevalence. I haven't heard anything else. I haven't heard your question. I just caught this seroprevalence because there is echo and I cannot clearly hear your question. Would you be so kind as to repeat?
Yeah, please. Because you are doing so many screening tests in this country. Because so many workers coming to work here. So for them, we do the screening tests. So many times the VDL test or TPJ test become positive.
I still cannot. I'm sorry, I cannot hear. Can anybody say more clearly? Because there's such an echo that I don't hear the question.
The question is about, you know, in this country, it is mandatory for residence visa, they have to do syphilis screening. So a lot of this it can positive. You know, is it, this is a false positive? Is it a true positive? So,
well, excellent question, thank you. No, it shouldn't be necessarily false positive, but each of us should know that once you get syphilis, you got a serological profile for the rest of your life. So some tests remain lifelong positive, and it means nothing. It's not active infection. This patient is not infectious. He can do anything he or she wants. But for example, TPHA, Treponema pallidum hemagglutination, I say, remains positive for the rest of our life. So we have to really differentiate. If the methodology is very simple, then it can be false positive. But this methodology is very sensible. Then once the patient had syphilis, it definitely doesn't mean the active infection, because there are other parameters, either IgM or something with ELISA test, or something with a very, very high titer of even RPR that will speak about positivity. So not every serological positivity means the active infection.
So In that case, what is the titer you consider to be positive?
It can be positive, but
no, I mean RPR, TPHA. What is the minimum or maximum that you
there is
consider?
no. It depends on every laboratory and so on. You usually have RPR negative or zero, so-called zero. Zero, depending on the lab. Zero doesn't mean negative. It means it was a kind of infection. And then you can have TPHA depending on 1,000 laboratories or 1,000 values. But if RPR is zero, or let's say in some laboratories up to 1 to 32, or maximum 64, or if IgM, any kind of IgM is negative, then it's okay. It depends on the lab and depends on the activity. You always judge the activity of the syphilis according to 2 or 3 tests. But if you have only IgG positive, it's nothing. If you have IgM negative, any kind of enzyme-linked immunoassay, or any kind of Western blot tests, if you want to confirm by Western blot, then it is important to have IgM negative, IgG, it can be positive, and if you have negative or very so-called non-reactive titer of RPR, that's okay. This person is not, but you know, every standardization, these are the principles, but that depends on the values of the lab you are performing the tests in.
Professor, we were actually enthralled by your passion, and as you rightly put it, venereology is an important part of our practice. So my question is a little out of the topics that you have spoken. We seem to be seeing a lot of monkeypox cases.
Well, thanks for the question too. Yes, it was not my topic, and even if it were, it would be very, very up to date. But I would lack, fortunately, I would lack the years of experience because this is comparatively new. When I sometimes teach about that, then when I list STIs, then I usually write ETC. And then I ask the audience, what have I missed? For example, I always miss something. Now I would have missed monkeypox virus. Definitely. It is present. We had some cases, I had some documents, and we perform, as probably you do, the PCR on monkeypox in some of our hospitals. And in some cases, this is the very important knowledge of dermatovenerologists, because these necrotic lesions might be missed. In some European countries, it was, you know, well, here again, 1-0 for Madrid. The higher number of cases in Europe were in Madrid, Brussels in particular, and something in Amsterdam. Now there is a significant decrease of monkeypox virus, maybe due to immunity, due to vaccination, and it seems the situation is better, but it's not gone. So the first thing is good eye of dermatovenerologist, and no other, I'm not sure if any STI person without dermatological training could recognize the lesions which are, papular necrotic and which remind of monkeypox. But thanks for the question.
Which vaccine are you using?
In which, how?
For monkeypox.
How do you mean which vaccine?
No, are you vaccinating people for monkeypox?
Yes. Not everyone. No, it's not a large, no. It is a kind of optional vaccine. Who are in danger? Well, the people who declare themselves or wish MSM population, and then the people, even the healthcare providers that used to come very frequently in the contact because you are very near to the lesion, And that time we did wear the corona masks, but still the people have to get very near in order to do that. So healthcare providers, MSM, and everybody wishing it get the vaccine. But I really don't know which kind of vaccine, because I was never accounted that there were many kinds of vaccine. It's not like corona. You have Pfizer, or you have like, it is the only one kind, I think. I don't know, maybe you have a different experience, but there is the only one kind in Croatia, and this one has been given to those who want to be vaccinated.
Thank you, sir. We also see a lot of dermatophytosis, which even seem to be sexually transmitted. Frankly, multi-drug resistant tinea glaburosa has become almost...
No, come on, let's be very, I mean, at least, I am mycologist at the same time, but dermatophytosis, let's be precise, can be sexually transmitted in the terms that any contact which is near can be sexually transmitted. But I cannot say that dermatophytosis is a sexually transmitted infection, whereas Candida can be a sexually transmitted infection.
Absolutely.
We have to move to the third presentation, Prof, because we are really behind the time.
Whatever you say. So that's something which I like the best, because you know, HPV infections are my life, and HPV infections are not another STI. That's STI with a potential oncogenic effect, and that's why the progression and the civilizational degree of the country is measured by the care about HPV. Again, it is as old as humanity, because we have the first writings about from the Roman time. I have to put my water here because otherwise it will go away. And this is, they didn't know it was HPV, but they knew it was infected. And of course, we still use this Latin term condylomata acuminata, which is actually genital warts in English. So, by the way, please, you are a very progressive situation here. You have excellent academic value. And I always like to teach these Americans that don't know Latin. So, it is either condyloma acuminatum, if it's one, but it's only histologically one, because it's always multifocal disease. So please, in plural, it's condylomata acuminata. It's a neutral gender. It cannot be condyloma acuminata. Whenever tell to everybody that I taught you so, please, because it can be either condyloma acuminatum or condylomata acuminata. Whenever I was twice at Harvard with even late Fitzpatrick, who was the author of the textbook and the head of department, and I always got angry when the Americans and even some about lichen amyloidosis. It cannot be lichen amyloidosis. It can be lichen amyloidosus. It's adjective. It is lichen sclerosus. It's not lichen sclerosis. So please be happy about our heritage. The first cases have been reported during the Korean War. And of course we have to excuse, because at that time their wives got about 6 to 9 months genital warts all around the United States. It was good for the science, but maybe it was not good for the marriage of those Korean War veterans, but c'est la vie. So this is still, we don't want to discuss. According to some authors, this is the most frequent STI. But if we want to be very precise, we say the HPV is the most frequent viral STI, because they say the trichomonas is the most frequent STI. Anyway, we won't go into detail. Well, whenever we use celebrities in order to emphasize the problem. Whenever you do anything about HPV, you cannot miss the name of Harald Zurhausen. Harald Zurhausen is the great virologist from Germany, who actually proved that the persistent infection with HPV 16 and 18 might lead to the cervical cancer. And he was rewarded a Nobel Prize for that. But I share the tip with you. If you want to receive a Nobel Prize, here is the recipe. First of all, you have to be a good friend of mine. Then, I invite you to the Congress in Croatia, like I have invited Harald Zurhausen, 2007, and next year you get awarded the Nobel Prize. So it is a very, very easy how to get a Nobel Prize. So it was a case with Harald Zurhausen, and between us is his wife, not only because it is his wife, but Professor Michel Etel. She is a great scientist, and this taxonomy of these clouds, alpha, beta, gamma, this is due to Michel Etel. So these are some of the reasons. I have talked about that. The burden is great, from the genital warts up to Buschke-Loewenstein, and I think each of you had a lot of experience with genital warts, all kinds of genital warts. And sometimes, although Buschke-Loewenstein is considered to be based on the low-risk HPV, sometimes it can be based on the high-risk HPV, and we have to be very careful not to discover if there is a squamous cell cancer beneath. Because all Buschke-Loewenstein should be biopsied for at least 2 or 3 sites, not to miss the malignant etiology. And today, we don't speak only about cervical cancer. We speak about a lot of cancers of inner or outer genitalia, or in particular of the oral mucosa and tonsillar and so on cancers, because today HPV can cause, the persistent infection of HPV can cause really, really many things. And we cannot speak only about cervical intraepithelial neoplasia today. The same procedure is on penile or anal region or wherever. So these are some entities. Historically, it used to be called erythroplasia K-Ra, but as we see, there are a lot of clinical features like that. There are some risk factors. The point is that this gentleman was, when he came to be seen by me for the first time, he was in the age of 42. So not only, as we used to speak before, we got penile cancer only on the elderly gentleman. This limit is going up and up. So this was HPV 16 based squamous cell cancer of the penis. So the same thing about anal cancer. We have to be very careful, because, you know, when woman is on the gynecological table, you have insight in her anal region, whereas the examination of the perianal region should be the rule of every venerological examination, otherwise we might miss something. And this high-resolution anoscopy should be the part of the examination. Unfortunately, it is still not like that in Croatia, and we always, I mean, when we have celebrities, if this helps us to reveal the truth, that's good, because Farah Fawcett, who has died many years ago, she has asked Joel Palevsky to spread out this slide, and Michael Douglas is not very good regarding his oral and tonsillar cancer, and both of these situations would have been preventable today if vaccine existed at the time of their youth, which it didn't. And the first lady of the world dermatology, who died 5 years ago, the late Professor Stefania Jablonska from Warsaw, she said it's very difficult. Because if you remember from my first lecture, that gonorrhea is excellent because it has 3 to 5 days incubation rate. Here, we speak about months and months. Incubation rate in HPV genital infections is per month. And just to make you sure that the STI people like the job, but like the life too, because we want to speak about ourselves, that we are the heroes of the day and heroes of the night. So please join us, because we, a part of discussing and working, we like the life together. And by the way, don't be put by the others, it is benign. Okay, genital warts are benign, but genital warts are sometimes very stubborn and very difficult to treat, and the recurrence rate is extreme. So don't get underestimated, that's important. Today we speak about proactive sequential therapy. We have published a lot of articles about it, but the point is that we combine ablative treatment in the office with the immunomodulatory treatment at home. That's the secret of this proactive. We did a lot about that. We were in different groups. And this is this famous article that everybody quotes. But, you know, to make the life more simple, that's exactly what I told you. Usually you give imiquimod or sometimes cinecatechin to the patient on Condilox at home, and you combine it with the treatment that you do in your office, either cryotherapy or whatever you want. Every treatment is good if done by a good provider, because don't let get quarreled by the patients. I went to Dr. Nisha Pramar, she was giving me podophylotoxin. Then I went to Mohammed Ahmad, he was giving me cryotherapy. Each of those might be good if applied well, and there is no penicillin for genital warts. Just one example, it was a very nasty case. And we did a combination of the treatment. Little by little, it took a lot of time and took a lot of energy. And we've combined, and this is the result. So, but it took a lot of time, and it's not always like that. There are some situations that we cannot do nothing. So I think this is an excellent result, but it takes a lot of efforts, time, energy, and nerves for the both patients and the doctors. And today, fortunately, we do have vaccination, as we can see. Today, we mostly speak about nonavalent, because in this case, more is more. We cannot say less is more. In this case, more is more, because we have a really very good rationale for giving the nonavalent HPV vaccine. It has been accepted. And that's what is important all the time, both genders, not women only. And it has been improved in the United States, in European Union, and we really do that. And please, this is my patent. Men are not mosquitoes only, because there were some kinds of, you know, prejudice that HPV is a female's disease transmitted by dirty males, which is completely not true. The both males and females might be the subjects and the transmitters of the disease. So please don't say that when the patients come, I did not come for myself, I'm worried about my girlfriend, my wife. It's not true. So, and this speaks more than 1,000 words. The country which has the greatest experience with the HPV vaccination is Australia. In Australia, they have really done a lot, and they have a very nice decline of genital warts. And there are a lot of studies today supporting HPV male vaccination, especially in young persons. Then again, there were a lot of questions about treatment abilities. HPV vaccine hasn't been invented as a treatment vaccine. This has been a prophylactic vaccine. However, there are more and more reports about the treatment abilities to some recalcitrant warts. So there still the reports are anecdotal, but it can have some treatment good options. Although basically it is prophylactic vaccine. And of course, it is basically against CIN and cervical cancer, but of course it is in prevention of anal, tonsillar, scrotal, vulvar, and many other cancers. And this is, once again, cervix is not exclusivity of the high-risk HPV. It has been the best studied due to cytological pap smears. But cervix is not the exclusivity. And we have definitely very, very great body of evidence showing that there is a very great benefit of vaccinating males as well. So any vaccine cannot be genderly specific. Vaccine should be genderly neutral, so both boys and girls should be vaccinated. And there is, unfortunately, in the whole world, in some countries, problems with the uptake. That's a great problem, due to many reasons. We don't have time, maybe on some of next regional academy, why the situation is such. And it is even a scientific term, hesitancy. Oh my God, I would take it, I wouldn't take it. The problem is that the children should be vaccinated. They, in the age of 12, 13 or 14 years, for that time they need the informed consent from their parents. And okay, I would, I wouldn't, that's the result of that. We're losing the time. In Croatia, since 2015, we got the vaccination for both boys and girls. It's free. It's recommended by the societies, but there is a little bit of, opposition and not response rate as it should be. We are very unhappy for that. We need this. This is one of the reasons. This is also part of STI education on all levels: elementary school, secondary school, university, and high health professionals, as you all are. Because COVID didn't stop the sex. COVID didn't stop the disease. I mean, not having sex is not an option. So even during the COVID time, the outpatient clinics should have been opened in one way or the other, because we have a very large number of STIs. It is a bomb that is going to explode all the time, not only sub-Saharan Africa. Whenever they speak about great numbers of STIs, they always say sub-Saharan Africa. Not only. We are all sub-Saharan Africa sometimes. By the way, by EADV, because I know that some of you are EADV members, I chair, together with Professor Gross and Professor Arne Wikström, EADV HPV task force. You are all most welcome to join us, because we need such intelligent and enthusiastic people like you. We had organized a lot of virtual meetings during Corona time, but this November it's going to be organized the EADV HPV course, which is going to be chaired by Professor Elektra Nicolaidou and me in Athens. It is still time. All of you who are EADV members, you can apply, and in that case, if your application gets through, you get completely all the expenses covered by the EADV. So I invite you, and if you say that you are from Dubai, then I'll do my best to come and push them a little bit. Yeah? So do that. And by this, I thank you most cordially for your attention for this 3 times for 20 minutes